Thank you, Mike. You heard my introduction before. My title and name have not changed, but I'm pleased to have some great folks on our panel today. Just to set the stage a little bit, we are going to talk about some of the issues that we're seeing at the states that have an impact on access to rare disease therapies, namely the creation of prescription drug affordability boards, or PDABs, as well as some attacks. I would say attacks. Let me say some efforts in the states to diminish accelerated approval, and that is a pathway for certain therapies, and that's a very important FDA pathway for a lot of rare disease therapies. But before we get into that, I'd like our panelists to introduce themselves, and we're going to start with Anna.
I think this is on. Oh, very good. Hi, everybody. Anna Hyde with the Arthritis Foundation. Our state director, Melissa, and I just played tag, you're it. So you already know my organization from just hearing about her, but I lead our government affairs program.
I'm Laura Bonnell, and I was a news reporter in Detroit in radio and television at an all-news station for 25 years. I had complete access to every legislator and the governor at all times in a heartbeat. I had 2 daughters with cystic fibrosis. I had to go from full-time to part-time so that I could be home or at the hospital with my kids when they needed their care. I was going to be an international news reporter, travel all over the world. Plans changed. I wanted to be with the girls. My husband was like, okay, I'll work full-time, you work part-time. We made that switch. Just before the pandemic, I decided to work at my foundation full-time. It's a foundation I started in 2010 to help other families with financial assistance for cystic fibrosis, lung transplant grants, college scholarships, and advocacy. And I decided in 2019 I was going to do it full-time. I went from having full access and lots of power with legislators and the governor to 0. Because when you're a nonprofit, who are you? Right? The whole image of nonprofits is much different. I mean, you can, they all know me, et cetera, but it's a different game. And it shouldn't be that way, but that's just the way it is. They all want to get on radio, they all want to get on TV, and they're fabulous. I mean, we work with all of them, but that's just kind of, how life went. My daughter's, Molly, is 28. She lives in London, England. She's doing great. Emily lives in Chicago. She's 26. She's also doing fabulous, and I will tell you a little bit more as we get going. Is that on?
I don't know.
All right. Hi, everyone. I'm Melanie Lendal. I'm the Senior Vice President of Policy and Advocacy for the ALS Association. Like Laura, I spent the first part of my career in journalism. I was a television broadcast journalist in various parts of this country, so I completely understand the desire to cover these stories around the world. Of course, that's not where we ended up. Today, I work with the association on policies at all levels of government, utilizing all branches of government, and some of my colleagues think that it is because of my bias as a former journalist that I often refer to the media as the 4th branch of government, where we also work.
Well, thank you. It's great to be here. Jason Harris, Vice President of Government Relations and Advocacy for the National Psoriasis Foundation. So I lead our advocacy program there, which is federal and state across all the 50 states, and looking forward to the discussion.
And you aren't in news or anything like that?
I am not in news. Yeah. No disclaimers over here.
So one of the issues, obviously, I just mentioned earlier, are PDABs, and these are prescription drug affordability boards. And they are really, we have 7 of them across the country right now. They're in various phases of operation. The first one that passed was in Maryland in 2019 or 2020. I'm getting my dates wrong. That is still being set up. They're beginning to do affordability reviews for drugs. But essentially what a PDAB is, it's a board that's been created by the state to look at the cost of of a pharmaceutical therapy versus its value. And if the board views that the cost of the therapy is not commensurate with its value, then in some states they can institute a price control. They refer to it as a UPL, or a upper payment limit, and they will tell you that it's not a price control, it's really a reimbursement limit, but a reimbursement limit is a price control essentially. So we are seeing a proliferation of these being introduced in states. Like I said, we have seven in that have been passed. I think the one that's furthest along is Colorado. They are in the process of doing affordability reviews on a certain amount of therapies. And what's troubling about the Colorado process is a rare disease therapy was included in their initial review. So this is questions for all the panelists, and we can start with Anna and go down. But you know, these were created ostensibly to help patients and consumers afford prescription drugs. But I think as we knew these could potentially create access issues for patients, but now some patient groups are paying attention to these now, and I would think are concerned about the proliferation of these. What does this mean for the patient populations that you all represent?
Well, I think it means a couple things. On one hand, we don't know yet because, to your point, this is kind of brand new and unprecedented. And Colorado being furthest along, we have the most lived experience there, but they still have not actually set whether they will end up instituting a UPL on any of the 5 drugs. We were very lucky that 3 of the 5 drugs are in our therapeutic area, so it's been really fun to work through this, which, so on one hand, there's operational concerns. Certainly, we've put forward a lot more questions than been able to sort of offer answers or recommendations because of all of the unknowns. I think one thing that's been really clear is that none of us know what we don't know, and that includes the staff within the Colorado Department of Insurance who are working on this. They're trying to figure it out alongside the rest of us. So some of the operational concerns we've put forward that could lead to patient access issues. One is in a crowded class, which is not true for CF and a lot of rare disease, but in a crowded class like rheumatoid arthritis, TNF inhibitors, of which Enbrel belongs and is one of the 5 drugs, what does a UPL on Enbrel mean for its ability to compete on formulary with the other drugs in the class? I'm not shilling for Enbrel in any way, but just as an example. Does it reduce its ability to get on formulary because it is now somewhat restricted in how it can negotiate? And we don't have a position, I should clarify, on the concept of UPL and all those things. It's not really our space. Our space is more the patient access side. So those are the sort of questions we think are really important to put forward. I would say this about federal processes as well. There are an awful lot of parallels between what's happening in Colorado and what's happening with CMS right now. And then the other kind of set of concerns, I'll let Jason talk about utilization management, so I'm gonna just tee you up for that in terms of patient access concerns. But the other concern I will mention is just the process of patient engagement and how difficult it has been to really work in a meaningful way to get the patient voice represented. I think this was covered a bit in the last panel, so I don't need to belabor it, but there have been efforts to try to get patient representation and patient engagement throughout the process in Colorado. It's been very difficult to find patients who can really engage, either because it's very wonky subject matter and it's just hard to kind of understand, or because the opportunities are fairly limited. So we're gonna do a listening session at this time on this date, and if you're not available to join it, then okay. So we've noticed there's a kind of a law of diminishing return to the extent that we have been able to get some patients to engage. When we go back to the well a second, third, fourth time, it starts to become a little bit too much. So certainly one of the recommendations we will be putting forward to other PDABs and CMS as they continue their work is to work very collaboratively with the impacted therapeutic area patient groups early on to come up with a collective strategy to ensure that there is meaningful and representative patient engagement.
And the state of Michigan, the rare disease community, there's 1 million of us, we do not want the PDAB to pass. It's inevitable, it's going to. Our governor wants it to pass. She doesn't completely understand it, neither do the lawmakers. But it's been set in stone that PDAB is this great thing and it needs to happen. And as my new best friend Melanie can attest to, it's sexy. PDAB is sexy. We're going to lower drug prices. Pharma is bad. That is the sexiness of it, and everybody's buying on it instead of understanding. That's all they're talking about. Pharma's bad, and this is going to save money, and it won't. So the rare disease community is working with MishBio, who also doesn't want PDAB to pass. But because we know it is going to pass, it went through our Senate in record time, like within 24 hours. We got a notice of a hearing, and people that were talking in that hearing weren't even from Michigan, and they were allowed to talk before we were allowed to talk. I actually couldn't testify because they let AARP speak first and other people outside of the Michigan community, and then it was passed. And we were begging them to slow down. This won't help the 1,100 people with CF in Michigan ever, because what we have in Michigan is children's special health care. So even when my children were on our insurance, we have private insurance, and then whatever our private insurance doesn't pay, this children's special health care covers for adults, children and adults. So there is no copay. So we have no issue with the money. It's $660,000 per year for my daughters to be on Trikafta. We're paying nothing. So there's no reason for the PDAB for us. We definitely are trying to have a voice. I've sent in amendments to say, put a patient voice on it. In Michigan, they're picking 5 doctors that don't know anything about rare disease. There's no patient voice whatsoever. Then we all ran to the House and we're talking with the chair like, hey, slow this down. Do you understand what's happening? It's not what you think it is. It's the prices that are going to be lowered are never going to impact us. Our problem is the pharmacy benefit managers. Our problem is everything you were already talking about, the step therapy, the prior authorization nightmare. Cystic fibrosis is never going away. They're going to have it year after year. It's a constant issue. So we're trying to teach them. So that's the biggest concern. The other thing that you said is that I can relate to is you've got all these parents who are in the middle of the shit, right? Excuse my language, but they're in raising their kids and cleaning the medications and getting them to the doctors and sitting in the hospital. They don't have time to watch this video, to come here. They're in the midst of it. It's only a few of us that are advocating for everyone. And like I said to both the Senate and the House, why aren't you holding Meet Us for Coffee or go into their communities or do a webinar and connect them on social media in every way? Because you are not educating your constituents who are your constituents. You are not doing them any favors. You are not educating them. You are not helping them. You're not reaching them. Thankfully, whether it's all talk, I don't know. The House promises that they're going to slow it down. I don't know if they are, but they've recessed. We're into 2024 now. So.
Yeah, Melanie?
So I'll say at the outset that the association does not yet have an official position on PDABs, but I do expect that that is something that could change very soon. And why do I say that? The first thing I will say is, what's a PDAB? Well, when you talk to most state lawmakers, they have no idea what you're talking about. You have to spell it out, and then you have to explain it. And to me, anytime I have to spend half an hour to 45 minutes explaining the potential ramifications of a bill to a lawmaker, we've got a problem. Exactly. I appreciate the intent of these efforts, but the problem is, like my colleague Anna said it earlier, we don't know what the ramifications are going to be. So the fact that we're going down this road, a road that could undoubtedly disproportionately impact patients with rare diseases, is frightening. What it tells me is we should not be going down this road right now. I understand why we are, but I cannot think of anything more difficult for families, who have a family member with rare diseases than to have a crazy patchwork, more of a crazy patchwork of laws across the country related to healthcare and costs than we already do by layering this one on top of it so that patients have a different rule in this state, and as soon as they cross over the state line, it's something over here. I don't think that is good for any patient, rare disease or otherwise.
Yep. Well said.
Okay, this is difficult to add on to. No,
I like
but-
the passion.
Yeah, no,
Thanks for this seat, by the way.
absolutely. So I think, I think it certainly is different, as Anna was referencing sort of her community, folks living with rheumatoid arthritis or arthritis that, is not a rare disease, and the same thing is true for someone living with psoriasis or psoriatic arthritis. And so, like Anna, we also had 3 of those 5 treatments in Colorado, and I would second all of the sort of comments on the process. I think that's a piece we're also really focused on is, there's the beginning process of how you're actually assessing what treatments to potentially review, right? What are those models? What's the engagement with communities like ours or even individuals to help select that process? So even going further back into that sort of look into transparency, I guess I would say. And then, once you get there, we've seen what some of the things with Medicare negotiations have looked like right now, and you're seeing states, it really is like mini IRAs to mini negotiations in a certain way. And so it is concerning, I think, when you think like, well, if the feds are doing this now, maybe we should wait and see what that looks like before just trying to do it in 6 or 7 different places. And then the people in the end making decisions is why are they in the positions they're in to be able to end up making decisions on the PDABs? So I think process is really big here, and then as Anna threw me utilization management, referencing if one treatment has a UPL or has that sort of that limit, if we're all being directed towards that because of the price, that brings up a whole host of problems for all of our communities when it comes to whether if the treatment maybe they've already failed, or just generally if it's not the right treatment for them that them and their physician provider decide to go for. We know the ramifications if you're not on the right treatment for 2 months. So, yeah.
And that's an important point to make, especially in a rare disease community, when there is not really anything that's therapeutically equivalent out there, and you don't have any options then. That's a very important point to make, actually. Laura, Anna brought up patient engagement and how important that is in this process. Where could you see, or do you see, RDACs playing a role in something like this?
Yeah, I think it's really important that, because you would have the voice, you would have all the representatives, and it's really important. No one is the bad guy, not the insurance, not pharma. Everybody needs to work together. That's really important. The sad thing that we saw in Colorado was initially they didn't even engage their RDAC. They didn't even ask for their opinion. That's what it's set up for. So until everybody said, hey, you need to consult your RDAC. And it's just, I think it's really important, though. You would have geneticists and doctors and everybody that would weigh in and that would have, some kind of, they would be able to
Expertise.
weigh in.
Seems
Yes,
like a scary word to them is expertise.
Right,
Yes,
exactly.
yeah.
Even when this whole process started for us, it's been years now, and we're on our 2nd sponsor. It's taking forever. It passed the Senate Health Policy Committee, and we were supposed to vote on it. Then that got delayed, so now we're looking at 2024. Yet PDAB is racing through. So I think it's really important because of all the things that we've talked about here already, because the rare disease community does need a voice, and everybody does need to talk to one another and say, here's what we're experiencing. I mean, I think when you hear someone say, oh, this is what I'm experiencing, maybe you thought it was a different way. I think that's really important. I am all for listening to the insurance companies, and I am listening to pharma, and I want to hear what your challenges are, and they need to hear ours. So I think that's why it's really important to our community, so everybody hears everybody's perspective. Thank you.
Great. Let's move on to a slightly different topic. There's been some attempts by state Medicaid programs, Massachusetts being one of them, I think. Tennessee had tried this, and some other states where they're restricting access or attempted to restrict access to therapies that have been approved under the accelerated approval pathway, and many rare disease therapies are approved under that pathway. So, Melanie, what are your thoughts on that?
I have a lot of thoughts on that. So I will say at the outset, this is not limited to Medicaid based on what we're seeing. Earlier this year, the FDA approved the first gene therapy treatment for a specific genetic form of ALS known as SOD1. So in ALS, you have about 90% of the population where we have no idea what has caused ALS. Then we have 10% of the population approximately that is genetic in nature, and about 1 to 2% is SOD1. This is an incredibly aggressive and fast progressing form of ALS. So the fact that we have a gene therapy treatment approved through accelerated approval in this area is pretty miraculous. It has been frankly life-changing for one of our board members who is a SOD1 ALS patient, and it has actually pretty much halted the progression of the disease for him altogether. There's still ongoing clinical trials, but the outcomes for people who have participated in the trials has been nothing short of remarkable. This is great news for the entire ALS community. But of course, it went through the accelerated approval process. As a result, what we are seeing is lack of coverage from insurers across the country, whether it's Medicaid, private payers, whatnot, and for a whole host of different reasons. We have one insurer who we are working with who has told us that they're not going to cover it until you've tried Riluzole first, which was the first ALS drug approved back in 1995 that has modest benefit. This is a gene therapy specifically for a specific form of ALS. So to ask a patient to fail first on something that we know is only going to slow down the progression by about 2 months, I don't know what that looks like. And then we also have insurers, and this is scary, and I'm sure some of my colleagues who have read ProPublica today will agree. We have had insurers say that, well, this is not a required drug under certain state prior auth laws, because this is a gene therapy, so it doesn't meet the definition of drug. So what we are seeing is, even though these treatments are getting approved through the accelerated approval process, the fights to get access to coverage and care is huge. And I only expect this issue to grow, particularly as the IRA becomes fully implemented.
And more gene therapies come on the market.
Exactly.
Yeah. Well, that's it for my questions, and I know I have the unenviable position of being the last panel of the day, but I wanted to open it up to the floor for any questions for our panelists. Yeah, Tara.
Yeah, so this isn't really a question, it's general comments. So in North Carolina, a year ago, June, I partnered with our bio, of course, because all art acts should be partnering with their bios, I tell them. And we held a legislative breakfast on access. I had a person from Duke Margolis in DC that came in to speak. I had Priya Kishnani from Duke, who's head of genomics for Duke, and Vandana Shashi, who was head of the NIH Undiagnosed Network, and patient advocates to tell their story. One hemophilia and one with SMA. And we talked about the gene therapies. And it's education. We had so many of those. We had 35 legislators that attended. And then after that, there was so much follow-up. I can't tell you enough. I'm at our legislature on a regular basis. I go to a lot of other legislators in other states. You got to educate, 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 educate. I suggest holding a legislative breakfast and then do follow-up with that. Have a one-pager about this. But access, we explained that's one of the top 3 concerns with the rare disease community. So I feel like education cannot be stressed enough.
Yeah, and I was just, we've worked on that together. We work with our affiliates in the states to do these briefings, and I would be if any patient organization wants to help and be part of one of these briefings, please come talk to me because we'd love to have your expertise. They don't want to listen to me, the trade association lobbyists. They'd rather listen to you guys and some of your patients, I think. Yeah. Yeah.
Comment and a question, but accelerated approval is just one of those things that we just roll off our tongue because we know what it is. It's not a lower bar from the FDA.
Right.
I think it just gives people that it's a different way of making the juice that's somehow not up to snuff. And so I think we just need to be cautious about how we use that and what audience we're speaking to.
Yeah, I mean, I think some payers have done a very good job of creating the false narrative around accelerated approval, and it's incumbent upon us to educate policymakers that this is an official FDA approval. It goes through the same rigorous process. It's just a speeded up process. Yeah. Yeah.
We know, we understand that the world doesn't.
Yeah.
I was just going to say, something that I've noticed, obviously, this conversation between PDAB and the Rare Disease Councils, the RDEX, pushing more of that focus back on the patient experience. This is why I like the rare disease groups better than the PDABs, because it seems like the appointments aren't always centered on getting a patient on that PDAB, which is part of the problem. You have people who are appointed that don't have the needed experience to really review this and talk about the affordability problems that exist in real life. I wonder what your opinion is in terms of, we have 8 or 9 states now that have PDABs, with Michigan's attention on it, though the governor has gone quiet on this now, even though it was her top agenda item in August. If she continues to have the national stage and highlights this, is there concern for more PDAB efforts in other states? And then where do you think it's headed to next?
There's definitely going to be, there's concern in other states. I mean, we're watching states intently. Illinois is one of them. Connecticut. There are a few states that are on our watch list for next year. There were some states that actually had bills dropped last year that didn't make it through because the sessions just ran out. But so we expect it to be active in those states, New Mexico being one of those. I don't know if you guys are hearing any other intel.
I mean, in regard to our governor, she is quiet on it now, a little bit quieter, but the word still was that she wanted it passed, and I think that was definitely the intent to pass it. I think if that's what you're asking, then the House is just looking to get amendments because it's going to pass in Michigan. I have no doubt that it will pass. So, yeah, so actually,
The House is
it's-
split right now.
yeah, it's interesting because there's just a lot of misinformation. I didn't want to name anybody. I was thinking, oh no, better not. But there's just a lot of misinformation right now. But if the House is sincere, which I believe and hope they are, they did say they were going to slow it down, and I sent them amendments. I got the CF Foundation to send them amendments. We got NORD to send them amendments. They've got a lot of amendments to look at. So we're hoping the patient voice gets on there and many other things.
Yeah, I definitely feel like it's the train's left the station conversation. Getting ahead of it is difficult, especially if lawmakers are using it as a checklist to say, I solved the affordability problem, we have a PDAB.
And it's being put, I mean, this is an idea that came from the Arnold Foundation, and that's a very deep-pocketed organization. So they have the financial wherewithal to hire experts to go around and talk this up with legislators, unfortunately. And that's a pretty big organization with deep pockets to battle against.
This is just my personal opinion. I am not speaking on behalf of the AF, but because I think we've kind of been talking around this, that the PDABs are a fundamentally flawed concept in that they only target one piece of the pie, and we all know that these problems are systemic. You cannot untangle drug pricing from rebating and other PBM practices. We all know that. I think that the PDAB members and staff in Colorado are realizing that, and they're having an oh shit moment to some extent. if I'm another state and I'm watching that, if they crash and burn, I don't want to be on their heels. So it's interesting because it's true that it's become this kind of domino effect, and other states are like, oh, they're first, I want to be second or whatever. But it's like, second to what? Failure? I mean, and maybe I'm wrong, and Colorado will turn out swimmingly and
I think
whatever. But
they're like the dog that caught the car. They're trying to figure out now how to do. It sounds easy and it's a great soundbite, but it's very, very difficult to do, and it costs money.
Right.
They don't realize there's fiscal notes attached to setting up these boards. And Maryland has had to go back to the legislature each year and ask for $1 million+ every year to get this board up and running, and they're still not up and running yet. So.
And just to add too, because you remind me of this, we took the letter from lawmakers that they wrote to the Colorado PDAB. All those lawmakers, I took it to the House and I said, call them. You got a list this big said, don't touch the CF drug, and there's no point in all of that. And call Colorado lawmakers before you decide. So we were glad to see that letter from the lawmakers in Colorado, and it did help, I believe, with our lawmakers.
All set.
Anyone else? Thank you. I appreciate it. Thank you guys for the good conversation and the expertise. You made me look good today up here. Appreciate it.